Mm, Good day, everyone. Thank you so much for joining me today. My apologies that we couldn't have a session yesterday. I think it was due to the weather that we had in our area. There was a problem with the internet connection. But luckily back online today. And I want to just cover an ECG. Those of you on the WhatsApp and Telegram groups would have seen the ECG already. And today we'll discuss it and hopefully go through the answer and management of such a patient as well. So let's get into it. It's not a very long presentation, but it is one I hope you guys will enjoy. So just get something up over here just so that it's a bit easier. There we go. All right. So we have today a 71-year-old woman with generalized weakness. Now, is a common problem. Something we often see in emergency departments, non-specific symptoms such as generalized weakness, fatigue, syncope with recovery, just general malaise, things like that. And in a 71-year-old male or female, an ECG would, of course, form part of your workup. So you are there in your emergency department. And my apologies, I've got a bit of a blocked nose. So 71-year-old, you've got them on the bed, you've taken all your basic bloods, and as part of your workup, you also do this ECG, and this is what you see. So when not very intimidating, it does get you wondering because if you follow this series of ECGs, you should be able to more or less get through it quite easily. But nevertheless, we're going to go through it and we're going to see what we can find. So let's start first by trying to figure out our axis on this patient. And as usual, we start with lead 1 and lead AVF. And in this case, we see lead 1 is positive and lead AVF also biphasic, but we'd say majority positive. And that would put us within the normal range. Now, we're going to look at the rhythm, and this is probably going to take us a bit of time. So let's have a look and see, because we can see there is probably something that's causing a bit of a rhythm disturbance, because we've got occasional irregularity in the rhythm that you can see, especially there, you notice it and things like that. So let's have a look and see. So what we see here is a pattern, of what looks like a possible T wave, followed by an inverted T possibly, and then we don't necessarily see a P, or that could be a P. So this is what we start to notice as we are going through. So it is a bit of an odd pattern. And when you see this, it can be quite confusing to see what could be the possible cause. Now, in this case, this is a slightly difficult example of the diagnosis that I'm trying to teach you all today, but hopefully you'll get it, once we've gone through it a little bit. So, and just a reminder to those of you who are joining live, I just want to thank you very much. And you're more than welcome at any time just to stop, ask me questions in the chat, or alternatively, if you're watching this later on, you can always ask me questions via YouTube or via the groups as well. So, what we notice is that we don't have a definitive P wave. We can't say for sure that we see a P wave here, and we can see what looks like an odd pattern going on there. So you could argue that maybe this is a P wave, but you can't really see for sure. Maybe this is a P wave and it's inverted. So there's quite a bit that's going on. Have you got a little P wave over there? And it makes it quite difficult because is this a problem where you don't have atrial function and atrial conduction? So let's take it a step further from there. So we can't really talk about the P waves just looking at it from this point of view. And what we notice then we go to so we can't talk about a PR interval or anything like that because we're not really sure about where our P waves are. And whenever that happens, I always advise people, if you can't see a definitive P wave on your rhythm strip, look for it somewhere else. Sometimes if there's cardiac rotation, if there is cardiac, hypertrophy, things like that, atrial changes, you may have the axis of the atrium changing. So the ECG may not pick it up in one plane, but it may pick it up in another. And if we go through here, we could argue that maybe this is a P wave, maybe this is a T wave, but at no point in this ECG could you definitively say, listen, I'm definitely seeing a P wave. Like for instance, you can see one there, but then when you go through the rest of it, you can't argue and say, okay, I definitely see one there. I maybe see an inverted one there, but am I seeing one there? So we do have an issue where we can't see a definitive P wave at any point. However, our QRS complexes are narrow. So what that tells us is that our ventricle is receiving its instructions to contract from above itself. So in other words, the AV node is not the pacemaker. So it's possible you could have hidden P waves over here, or you could have a junctional rhythm, and a junctional rhythm being, of course, that you have uh, intrinsic pacemaker cells, but not the SA node that have actually taken over here, and that may be causing the problem. Okay. We notice that our QRS complexes are relatively regular if we look at them, but then you get this occasional just jump, you know? So this is where you need to have a look closely and see. So let's have a look and see. So we can see here we've got them. And if you look at the rate here, the rate is about 150. Here again, it's about 150. Here again, 150. And then suddenly it's 100. And then again, you've got 150. Here you've got closer to 100. 150. Again, 150. Maybe 150. 150. Again, maybe 150, and then again 100. So it's not as though you have a regular irregularity as well. So it's unlikely to be a heart block or, a Morbitz type 1 or Morbitz type 2 that we've talked about before. So this is an irregular block. So what can we see in those where we've got an elongation, let's say? Maybe it will give us a better idea. So let's try and concentrate on that part for now. Let's try and put something there just to try and give us an idea of what may be going on. I'm going to try my best to get it up over there just to get our attention to that part. So what we see here is that we've got our QRS, and then we've got what looks like an inverted T, and we've got another wave that comes out over there. And if we look at the other one, even though it's a bit more, the ECG is obviously moved or something like that, we can see a similar pattern sort of developing over there. All right. So it may be difficult from this particular one to say, okay, this, I know 100% what's going on, but we know that something is happening, And if you look at the two waves, they're quite similar. So these could, in fact, be two P waves that are actually getting through, or it could be a T wave and a P wave. But I will grant that it is quite difficult to make a diagnosis just based on that. Okay. All right. And then, like I say, we've got an irregular heartbeat. So at some majority of the time, it's about 150 beats per minute, and then it suddenly will drop to 100. And I'm sure if you were to put this patient on a SATS monitor, you'd find that you'd get 100, 150, then sometimes 110, 108. It would probably just go up and down ever so slightly. So let's have a look at the each zone of the heart, and let's see what we get. So if we look at lead 2, again, we see these inverted waves that are here. Here again, we see them there, but it's exactly what we saw here. And in lead 3, we see this very unique pattern that's taking place over here. Now, lead 3 is actually the one that gives us the best idea of what's going on, and we'll get back to that just now. But it just looks like very wide waves, and it has a particular pattern to it. And in AVF again, we see these these inverted waves and this odd pattern that we're seeing over there. So for most people, the diagnosis would actually become quite clear once you see this. So this particular, let's just try and mark it off over there, just so that we can see it a bit better. Just try and put it over here. So we're just trying to mark out lead 3. So if we just look at lead 3 in isolation, the one thing that you'll note is that it has what we call a sawtooth pattern. All right. So it looks like the teeth on a saw, what was an old-time jigsaw, all right, or a wooden saw that you would normally use to cut wood. All right. So if you were to turn that, if you can imagine that this is the actual saw, this is what the teeth of that saw would look like. And a sawtooth pattern is very indicative of atrial flutter. So atrial flutter is the most likely diagnosis looking at this particular one. And atrial flutter would also fit with what we are seeing over here as well, because this also at times looks like a sawtooth pattern. And if you now look at other leads, specifically the inferior leads, you can start to notice that it is looking more and more like a sawtooth pattern. So atrial flutter is quite difficult sometimes to pick out because it depends how many atrial waves you get before you get one that's transmitted to the ventricle. So for example, if we were to look at this, for example, we're probably getting maybe one, and then on the second one, it's going through. And you may get different types. So I'm just going to try and, sorry, just try and draw it out here. It's not, okay. So get a pen. All right. Let's get a nice color in there so everybody can make it out. So typically what you would see is that you would see the sawtooth pattern. And sorry, I'm trying as best as I can. And then you get a QRS complex. All right. So let's take, for example, this one that I've drawn. Okay. So this one we have drawn, you can see you've got 1, 2, 3, and then you've got a QRS. And then you may, for example, have one that's a bit more drawn out. So you may have, for instance, in this one, which is like a 1, 2, 3, 4, you could argue even 5, and then you get a transmission. But in this one, what we are seeing is we're getting like a 1 and a 2, maybe even a third, and then you're getting 1. And here you're getting 1, 2 again, and possibly a third. And here you're just getting 1. And on the second one, that's why here it looks so difficult. And this could be what we call a 2-to-1. So that means for every 2 atrial contractions, so for example here, for every 2 atrial contractions, we're getting 1 going through to the ventricle. So you have the atrium fluttering. It flutters once, it flutters twice, and the second one, the impulse gets through to the ventricle. If you were to look at one like this, for example, you're getting 1, 2, and on the third, it's probably getting through. On one like this, you're getting 4. On one like this, you're getting 5. Now, 1-to-1 is not really common at all. In fact, you don't really see, you wouldn't diagnose an atrial flutter based on a 1-to-1 because that's not really the definition of a flutter. So what is atrial flutter? Atrial flutter is just basically the atrium functioning at a much higher rate than the ventricle. But we'll get into it in a little while so that you can actually see how we get to that conclusion. And, it's one of the illnesses of the atrium that's prone to causing thrombi, that's prone to causing ischemia. So it is something that we do have to worry about. Okay, so we've had a look at the inferior leads. We can have a look at AVR. It doesn't really tell us much, except that maybe we've got a T wave there, but we're not 100% sure. If we come to leads V1 and V2, we notice a Q wave in V1, Q wave in V2, not really an ST elevation or anything like that. But the Q wave here tells us that there's possible ischemia, maybe even current ischemia or old ischemia. So when you have a Q wave in V1 isolated, that's never a worry. It does happen. But once you get in V2 and V1, as occurs here, then you really have to start thinking that there's a good possibility that this patient has had previous ischemia of the septum. Because you remember V1 and V2 are the septal leads. All right. So it starts making us think, okay, and could ischemia be the reason for the flutter? Is that why we're having this electrical abnormality? If we come to V3 and V4, or anterior leads, we can see a slight ST depression over here. It's difficult to say whether we're seeing a T or a P, but we can see this almost a sawtooth pattern, but it's much more evident here on the inferior leads. And in V5 and V6, again, we see the slight ST depression. And in leads 1 and AVL, on lead AVL, you can see again more of the sawtooth type pattern. Lead 1 again has maybe these inverted T waves and things like that. So what we have here is a patient who's got atrial flutter and who's got a possible ischemia, acute ischemia, maybe an NSTEMI of the lateral side, and maybe an old or even a current one of the septum. Now, the thing is with Q waves, you must remember that it just tells you that there's ischemia. it tells you that there's ischemia of the entire wall. So it's a full thickness ischemia. It just doesn't tell you when. So it could have been 10 hours ago, 10 years ago. It's difficult. So you can't age an infarct based on this. But based on history, you could probably, get it out of the patient. I mean, they may have been treated. They may well know that they've had this problem. So that's how you take it from there. So you're now sitting with this patient. How are you going to proceed? So the first thing is, like we say, atrial flutter is one of those diseases that could possibly cause thrombi within the atrium. So you've got to think about that. Your patient is tachycardic on occasion, so maybe you need to start thinking about controlling the rate. And your patient is also possibly having an ischemia. So you've got to think again of thrombolysis, So thrombolysis is probably one of the main things that you're going to think about here before you start getting the heart rate down. The reason being, once a patient has thrombi, and if you suddenly slow the heart down or you get it into just a normal rhythm, there's always a possibility that they may embolize. So you've got to think of that, especially in the emergency department, before you rush off and immediately think, okay, you know what, I'm going to just, get this patient's heart rate under control and then proceed from there. So let's have a look at the answer of what we've got. Oh, sorry about that. Just take out all of these drawings. Let's just clear that. Sorry about that. So as we can see, we've got an atrial flutter with variable block. So the variable block just means that sometimes maybe two atrial pulsations to one ventricular, sometimes three, sometimes four. And the rate they've got it as 130, they've just sort of averaged it out. We can see they talk about a previous septal MI, which was what we picked up on V1 and V2. And the T-wave abnormality is consistent with the lateral ischemia. So, this patient could be having an acute ischemia, which is why she's feeling so weak as well. So atrial flutter occurs in this case primarily with the 2-to-1 AV conduction, but several areas of 3-to-1. So it produces this irregular rhythm. So as we had said over there, that sometimes, and especially with 2-to-1, it's very difficult to make it out. In this particular patient, I think from lead 3 is probably where you'd get the best idea of the fact that this is an atrial flutter, because it has that definitive sawtooth pattern. And for most patients who present with atrial flutter, it may not necessarily be as difficult as this to make it out. The sawtooth pattern tends to be a lot more identifiable. So that's the difficulty of seeing that in this case. All right. But as usual, now we've got to think about what are we going to do. So you've got to have an idea of what you're going to do, because we've talked about tachycardias before, we've talked about ischemias before, we've talked about atrial problems before, but now we've got a specific problem, which is atrial flutter. So you have some treatment strategies. So the first thing is, of course, rate control. If your patient has a very high, with tachycardia, very severe tachycardia, you would have to consider possibly, giving this patient beta blockers, diltiazem, verapamil, ACE inhibitors, something to possibly bring down the rate. However, considering the patient may have clots, this may not be your first point of call, but it's just giving you an idea of what you can do. And of course, you may need to control the rhythm as well. Now, rhythm control means getting rid of that atrial flutter. So there's a few ones that you can use, but I must be honest, these are generally not done in the emergency department. The reason being that once you get the rate and rhythm under control, but you haven't necessarily excluded the patient having thrombi and things like that, you may run into trouble. In other words, you may well bring the heart rate down or even get the rhythm under control, but the patient may then start to embolize, because now you've got an atrium that's now functioning properly. So it just starts to shoot off emboli everywhere, from thrombi. So if there's no thrombi, then it's fine. So generally what we say is that if the patient has had this condition for less than 2 weeks, so whether it be atrial fib, whether it be atrial flutter, even atrial tachycardias, things like that, wherever the patient has an atrium that's not functioning properly, if they've had it definitively for less than 2 weeks, then you can go ahead and attempt rate control and rhythm control without necessarily looking at the risk of thrombi being present in the atrium. So that would normally entail you having a definitive history. In other words, the patient's had an ECG a week ago, and a week ago there was absolutely no evidence of this. And now you've got a patient with definitive evidence. You can say, okay, this is a new thing, we can go ahead. However, that's very rare. The majority of the time, the patients themselves have been sick for quite some time. They may have had previous ischemias. They may have not been treated for a month or two. So it's very difficult to say for sure this is acute. So in these patients, I'm just giving from my own personal point of view, I prefer to treat them conservatively. In other words, I assume that they've got thrombi. I don't rush ahead and say that I need to control their rates and rhythms. So I'll first investigate that. So with echocardiography at the bedside, or if you have it available immediately at your, at your beck and call, no problem. You'd want to look for your D dimer levels, you want to do your clotting profile and things like that. All right. So how do you manage this patient? So there's two types. You get stable and unstable. Now, luckily, the majority of the time you'll have the stable patients. It's not very common for atrial flutter patients to come in unstable, but it does happen. The majority of them will come in with discomfort, tachycardias, palpitations, but they're not necessarily unstable. So you do your 12-lead ECG. And as for any type of tachycardia, we always look for blood pressure. So if your patient is hypotensive, then you consider your patient unstable. If your patient is normotensive, it's very likely that they are stable. The reason being the hypotension is normally what leads to ischemia and chest pain, leads to heart failure, leads to decreased level of consciousness and things like that. You have to consider underlying causes. So what are the two most common: hyperthyroidism and electrolyte imbalance. So of course, if you can correct those, you may not need to use any others. All right. So if you do decide on rate control, then you can use beta blockers, calcium channel blockers, ACE inhibitors, things like that. Digoxin, you can consider it in patients with heart failure, but I would do this under direction of a physician or an intensivist. I wouldn't just go ahead and give them digoxin in the emergency department. And then anticoagulation, you need to look at, the score here, which we'll look at in a little while, which gives you an idea of how at risk your patient is for thromboembolism. And you start anticoagulation if required. Okay. And then your patient goes for elective cardioversion. So that's normally done by an electrophysiologist or a cardiologist. Okay. So what do you do if your patient is unstable? Then, of course, you need to look for signs of instability, and the main one being hypotension, which leads to the others. If you don't have hypotension, it's very unlikely you'll have any of the others. So if you have an unstable patient, you can do an electrical cardioversion of about 50 to 100 joules is the treatment of choice for unstable patients. And if you have patients with a suspicion, you suspect they could have thrombi, you've maybe done an echo or there's a history that's suggestive of it, your patient may have had previous emboli and things like that, you can consider thrombolysis at the same time. Now, in this particular patient, 71, it looks like she's had previous ischemia, has probably current ischemia and atrial flutter, and considering the age, she has a higher risk of thromboembolism. So it's the type of patient that you would probably thrombolize and cardiovert at the same time, be it chemically or electrically. If this is, sounds very intense, it is, because you are making a life or death decision for the patient. So if you are not sure, rather ask. Rather be 100% sure before you go ahead and do any of it. All right. So the other thing, of course, you can do is chemical cardioversion. Now, in South Africa, we use mainly amiodarone. Places like Canada and the US, procainamide is currently used. The first thing I would do myself is still look at the risk of thromboembolism. Supportive care, IV fluids, and you monitor for complications such as embolization. So that is a little caveat. Now, if your patient is crashing, your patient is basically going into cardiac arrest, and you have the ability to, has such severe hypotension, decreased level of consciousness, is in such severe failure, and you don't have time to wait for all of the results to come back, or you don't have the ability or the access to an echo, and you go ahead and you do this, then the only thing is that you look for the possibility that the patient may embolize. So if your patient is showing signs of embolization, so suddenly your patient becomes weak on the right-hand side, suddenly your patient goes into respiratory distress, you've got to immediately think, okay, I need to thrombolize this patient immediately. It's not to say it's a complete contraindication to cardiovert the patient. You just have to think about it. So this is the score that I was talking about. So, and now this is, they've got it very nicely on MD Calculator, the website, and it does the calculation for you. So it basically takes all of these things into consideration. So CHF, hypertension, age, diabetes, previous stroke, vascular disease, sex category, different ages, and then it works out a score for you. And of course, the higher the score, the greater the chance of thrombotic disease, and the higher the chance of thromboembolism. So you can use that as a basis for deciding on thrombolizing or not. Okay. Now, thrombolysis depends on what you've got available at your facility. It may be something as simple as heparin. You may be working in an area where you've got the new oral anticoagulants. There's a lot of things that you can use. You may only have access to Clexane. You may have only access to warfarin. It doesn't really matter, just so long as you get something in there so that the patient doesn't immediately clot. But ideally, if you were working in the perfect scenario, as soon as you get this patient, as soon as you see the ECG, you would do the echo, look at the atriums. If there were thrombi present, you would immediately thrombolize the patient. If your patient was stable, then once thrombolysis is done, you would consider rate control and rhythm control, and then take it further from there after having done your investigations. This is the type of patient probably require an ICU or high care setting, shouldn't be treated in a ward. And ideally, this type of patient, even if you've stabilized them, should be transferred to the highest possible care that's available in your area. So be it a regional hospital, a district, a tertiary hospital, a central hospital, whatever it may be, but that's how you would approach this patient. Okay. Right, and that's just a little joke to end off. Sometimes I feel like my heart is telling me this, but so I'm not sure if there's any questions or if anybody would like to know anything. And if not, it's not really a problem. It's not to worry. It is a nice ECG to see because it's not a common ECG, but it shows a relatively common problem. Now, if you work in an emergency department on a full-time basis, you can expect to see atrial flutter a few times a year. It's not as though every patient coming in is having an atrial flutter. Atrial fibrillation is much more common, but atrial flutter is definitely, something that you would see at least a few times a year. And luckily, majority of the patients are relatively stable, but present with symptoms such as generalized weakness, palpitations, tachycardia. And this patient, of course, had a more extreme version now, where she's also got ischemia over and above that, which may or may not be related to the atrial flutter as well. So if there's no question, I would thank you for joining me live. And thank you to those of you who will watch a bit later on. But Thank you. Somebody's put something in the chat. No, thank you very much, Dan. I appreciate that as well. And yeah, keep well and enjoy the rest of your day. And hopefully tomorrow we'll have another session on something else. But I really do appreciate it. Thank you for those who have joined. I see a couple of people have left. And yeah, hopefully we will carry on again soon. Okay. All right. Keep well, everybody. Bye.